you want to say something?
Yes,
Yeah.
I do. And you don't even know this, but this year I was forced into Medicaid, Medi-Cal. I live in California, and I'm really glad that they did expand. My accountant is not good enough to be able to avoid taxes for 20 years, but there are years where I have no taxable income. Now, that doesn't mean I don't have any income, it means I have no taxable income. So when my exchange got my tax returns this year, they said, okay, we need to have income documentation. I said, well, I can't provide it. And they said, fine, you have to go on Medi-Cal. I really didn't even have a choice. The open enrollment was closed. So anyway, I'm having foot surgery on Friday. It was scheduled last August. And it wasn't from getting the referral done. It was because there was only one doctor and he's all booked up. I also have treatment for glaucoma and double vision. So I had to make an appointment with the primary care doctor, get the referral, and finally the first doctor they sent me to, I call in and they go, oh, we don't treat glaucoma. Sent me to another one and another one. And then finally they sent me to somebody, they wanted to send me to somebody 2 hours away for glaucoma. And it turns out in my area they have one ophthalmologist that treats glaucoma, and he doesn't take new patients. So I am a very strong patient advocate, and I was able to get an appointment with him. So I get my refills of my meds, and I said, okay, I'm also having problems with double vision because he's also the strabismus specialist. And he said, well, you have to make another appointment. Now, I only have problems with double vision when I'm driving. So, I mean, it's not really an emergency.
You're driving 2 miles for 2 hours each way.
So anyway, I come back and I see him and I'm beyond his scope. He can't handle it. So he wants to refer me to Loma Linda, which is an hour and a half away. And I'm declined because he's the strabismus specialist in my area. And he says, I can't do it. They send me back. I get the appointment 2 weeks ago. I drive an hour and a half there. I get there and they had canceled my appointment. And I never got a message that the doctor had canceled my appointment. So I made a 3-hour round trip for nothing. I go to reschedule that appointment, and he's a pediatric specialist. He only sees adults a half a day every 2 weeks, and oops, you missed the next one. So my appointment now isn't until January. Now, I've been dealing with this since June. And I have been dealing with eye issues since I was 10. I know exactly what I need. I need a Fresnel prism with a 1 or 2 deviation, and I can't get it. And so I've actually started the formal process now of referring outside my network to my old ophthalmologist. I can go in there in 5 minutes. He can give me what I need. I'm frustrated.
So imagine clients who don't have that level of knowledge or experience.
Exactly. Exactly.
Yeah. So let's put on your insurance hat for a second, right? And we'll be kind. Because I think we do, as a community, really understand and realize that we can't continue the cost of healthcare at the pace that currently exists. And we also, I think, realize that, and as great as what the ACA has given us, that there were some challenges in terms of the implementation of it, and particularly young, healthy individuals who were intended to sort of help support the process and the business model didn't necessarily materialize in the way that we had really hoped. So the result of that has been, to some degree, that the insurance companies had to sort of rethink about the way in which they are able to cover care for this massive population of people who are really sick, who are sick enough, right, to your point. So when you hear some of these conversations, or when you think about things like the cost containment strategies that we talked about, can you help us really sort of understand behind the curtain what are those conversations? Because it's people like you who aren't saying, I just want to get all these people out here, right? So therefore, let's put these things in place. It's people who are trying to say, how do I manage this and provide some level of coverage for some people? So help us understand sort of what that thought process really looks like. And when you hear that it's not working the way in which you had hoped, what sort of is happening behind those doors?
You presume that I was actually invited into those conversations, and I, of course, was not. So I spend a lot of time at meetings with people with cancer or people who take care of cancer patients. And I think we're special. on the other hand, I don't think the people making decisions about healthcare necessarily think that way. And I think what we're seeing clearly in healthcare is an attempt to approach population management sensitive to the rising cost of cancer care. And everybody within the cancer ecosystem, sadly, I think, feels it's not my problem, it's somebody else's fault that this is happening. I think all of us have to take ownership and recognize that there are going to be opportunities for compromise going forward. So let's talk about networks. Everybody blames the insurance company for narrow networks, so let me share something with you. The reason that academic medical centers are out of network for a lot of the exchange plans isn't because the insurance company didn't offer them a contract. It's because the academic center didn't like the contract. They didn't want to get paid what the health payer was able to pay within their budget. They opted out. Now, you are not going to read that anywhere, but I swear to God, it's the truth. Okay. So I think Medicaid is a challenge, right? Why is Medicaid a challenge? Because Medicaid has a budget. They set a certain pay line. You are not mandated to be a Medicaid provider. If you're not mandated to be a Medicaid provider and you don't like what they pay, you don't take it. My practice took Medicaid. We had a policy in my practice, we didn't turn anybody away. But I understand why some healthcare delivery entities say we simply cannot do that. Now, I'm not going to tell you that I have the solution to that, but I think to pretend that there's a clear-cut villain in this is just a mistake. I mean, it's a complex system. Shoot, we start talking about cancer care, we got to start thinking about what are the elements of cancer care that are driving up the cost of cancer care. And we have to take some long, hard looks about why things cost what they do and how much we value them. So what is our role? Let's decide what we think is really important that makes things better for patients. For example, I think one of the other absolutely horrifying statistics in your report is how few patients felt they got adequate social and emotional support. I find that really distressing. It doesn't necessarily surprise me. It more like disappoints me. Now, I think we need to drill down exactly on what the specific deficit is. But again, I think when I was in practice, my view of the solution to that was team-based care. It didn't need to be delivered by a social worker, but it had to have, my patients needed to feel that they were being cared for by a team and that every person on that team had a voice in how the management was being delivered. We don't do that enough. We just don't do that enough. And I think we can improve the patient experience and maybe even the patient outcome if we do that. Because as you showed, if social and emotional needs are not met, people don't fill their scripts. So that's pretty alarming too, right?
They go to the hospital and it costs that.
Yeah,
right. So one thing. So I think, going back to your original question, I think the issue regarding how healthcare is delivered may ultimately come to the point that we need to sit down in a room, lock the door, and say, okay, so if we're going to build an insurance benefit for cancer patients, what does it look like? So let's take specialty pharmacy and high co-insurance for cancer drugs. That was not a solution built for cancer,
Correct.
right? I mean, quite the contrary. That was a solution that was built for, and I'll borrow something the keynote speaker spoke to, situations where consumerism drives up cost, where there's choice. Choice about drugs that might be equally effective, but one is far, far more expensive for management of a condition. That is not, that's not palbociclib. Let's face it, right? I mean, palbociclib is a revolutionary drug to treat breast cancer. We should encourage patients to take it because they consume fewer resources and they're healthier if they take it, right? I mean, it's just bass-backwards, right? So maybe we need to sit down and think about, so if we were to do things for cancer and say, all right, forget about the way the insurance world works for managing a population, how would we adapt the resources to optimize, then I think we actually might move things forward. Now, of course, all bets are off the table now since nobody knows what's going to happen after January the 20th. We'll just leave that aside because I'm apolitical and I don't want to talk about it. But I think, irrespective of what happens in Washington, I think there's going to be an opportunity within the private sector to start looking at these kind of really innovative things. Because to some extent, a lot of this stuff that's been started by the ACA, that ship has left the station. You know, that is gone. And we need to figure out how we can optimize the care delivery model for our patients.